Welcome, doctors, to our first module. This is Dr. Lavi, and start. A call to action if there ever was one. It is a very suggestive first slide telling you if you have patients in your practice that are 7 or 8 years old and they have either transverse, sagittal, or vertical aspects to their occlusion that require correction, start. Now is the time. We have the tools to do it. Please do start. It is also an acronym that will describe, as you will see, 5 basic physical characteristics of the pediatric aligner that will help you start with early treatment. The only thing is, we do not call it early treatment, as you will see. So, our purpose is to show you how Invisalign First is redefining orthodontics. We are no longer going to be calling it early interceptive treatment. Rather, we will call it timely comprehensive treatment. Of course, Align themselves, I'm trying to cover it, but you can't cover it for long. If you go on the website, you'll see mixed dentition needing early interceptive treatment. It's one of our goals to change that up. We will be calling this timely comprehensive treatment for reasons that we will show you. Now, of course, early interceptive treatment does exist. We're familiar with that. This is what I would call early interceptive treatment. It's early because it ought to be early. It's interceptive because it's not comprehensive, right? We're trying to achieve limited objectives, whether it's to use a Hawley with a finger spring to resolve an anterior crossbite, or an RPE for airway issues, for skeletal transverse issues, a headgear to move the upper jaw backwards, or a headgear to move the upper jaw forwards. These are important appliances. They have a place. They are, however, limited to their objectives, and they are certainly interceptive. You want to catch the patient early and to get in with these orthopedic movements. So those appliances have the place, but those are not the appliances of which I speak today. They are not the subject of our course. The subject of our course is the aligner and what it can do in addition to these interceptive appliances that makes it so powerful and so comprehensive. Now, before we get into how powerful and comprehensive it is physically, it is also very comfortable physically, and I think that that's important. In other words, listen, compliance is an issue for all orthodontic patients, even if it's for fixed appliances. Certainly for early interceptive appliances that we showed you, whether it's a Hawley or a headgear, those are very difficult to do. Of course, an RPE is cemented in. There's a lot of discussion in Align where the new IPE is now in vogue, and they're certainly seeing great results out of that IP appliance. We will discuss some of the IPE, which is the Invisalign Palatal Expander appliance, during this course. And those are for those skeletal movements. But for our purposes, moving teeth with superior comfort without any emergencies, the alternative to what would be called otherwise a 2x4, or any kind of appliance where you have the brackets bonded on some adult teeth, but you don't have a lot of adult teeth, and you have now wires that you're trying to put bumpers on, you're trying to figure out a way to reduce emergencies. All of that is done away with the plastic appliance that is simply removable. It's great for oral hygiene because the patient can remove it, eat, wash their mouth out and clean their mouth and put it back in. They actually do not like putting the appliance back in, usually, unless they're gross kids. They don't like putting it back in to a mouth that's dirty, and therefore our hygienists in our office have noted that their oral hygiene is actually improved, not improved relative to brackets and wires, improved relative to not having orthodontic treatment altogether. So that's very profound indeed. Of course, the chair time is different. If you're whatever objectives you're achieving, if you know already ahead of time digitally where you're headed and you know that the aligners are fitting, then you can actually send the patients out for 3-4 months at a time, as we will see. And we'll talk about all of that in our modules and how we handle workflow and how it really has increased our bandwidth by at least 10x. But it's also just something that the patient likes, right? The patients and the parents don't necessarily want to come in on such a regular basis. And so this is convenient both for doctors and for patients. And we will talk about that. This no IPR thing that I wrote on the bottom, well, it's almost symbolic. It's not just no IPR. It's really all of the stress that we associate with aligner therapy that some doctors don't like, whether it's very specific attachment design or how much compliance are we going to get from adults who really ought to be giving us 18 to 22 hours. And if they don't, then they get aggravated and they start going off the rails. Or IPR, how much IPR you should or shouldn't do in order to achieve certain objectives. Most of these questions are not relevant to the pediatric aligner. It's a stress-free Invisalign experience for the patient and for the doctor because the patients are biologically and emotionally flexible. Also, because of their flexibility, they don't need to wear it 18 hours, as we will discuss. If they wear it at home and they never skip nights and they're more or less in the vicinity of their liner all the time, they are so young that they're getting beautiful results. Sometimes we find parents and children together in treatment, and the parent is becoming resentful of the child. They say, "Hey, I'm wearing it a lot more than the child. Why is it going so much better for them?" And the reason is because they're simply more flexible. They're children. They're better at this. And so it is the beautiful thing to be able to offer them that treatment modality. Let's talk about the physics. Let's get into it. Okay. Here you have the timeless design of the Holly with a finger spring, with the metal going in some undefined vector with an undefined amount of force that pops out if you overactivate it. It just doesn't do anything. If you're underactivated, you don't really know exactly what you're doing. And are you really addressing all of the issues? After all, when you have an anterior crossbite, certainly you want to treat that patient immediately. But what kind of treatment does the patient need? Does the patient need differential amount of forces on the incisors? Does it need, in addition to the upper incisor, does it need the lower incisor brought back into bone? Very often, that certainly is the case. After all, the patient is an anterior crossbite. Are there any other issues in terms of room for the laterals or anything that needs to be addressed? Well, almost invariably there are. And yet the Holly with the finger spring is a one trick pony, right? It's limited. It's trying to somehow resolve this crossbite. It's not necessarily predictable or efficient, but it's trying and it can be useful for that purpose. Whereas if you are starting on what we would consider a comprehensive treatment with a pediatric aligner, you're getting all of the benefits, as you will see, and it becomes a much more comprehensive. So this is not early at all, right? This is certainly timely in the case of the anterior crossbite, but as we will see, it's timely even in other cases that are not as much with urgency. But it's also not so interceptive. It's more comprehensive. Look at this punchline of every joke that I say with regards to pediatric aligners, how the midlines are on. It's not our primary objective when we're treating pediatric dentition. And yet we get it every time because we can. We program it in. But not only are you getting the midline correction, along with that comes making room for the laterals, some transverse development. Of course, the lower incisor getting back into bone is a very important feature. Doing the upper and the lower and coordinating those two arches together. These are very important features of our pediatric aligner therapy. Of course, no two patients are alike. No two snowflakes are alike. No two crossbites are alike. And here, the ability to guide these teeth. And again, the lower dentition together with the upper dentition, closing diastemas, guiding laterals, not just a central and crossbite, guiding erupting teeth. These are all incredible things that we can really essentially only do with a pediatric aligner appliance. And it is that which we're trying to teach in our course. So this is neither early nor is it just interceptive, right? Over here we see our dear friends, Jason, who had a crossbite. We wanted to keep maybe this central where it was, maybe the upper right central we wanted to move over. That kind of differential force can be done in other treatment modalities, but it's so difficult. And within just 8 months, the lower incisor was put into place, the midlines were spot on. There was some sort of orthopedic development that can only be described as a three-dimensional orthopedic effect that happened that I want to discuss. And so it's not just interceptive. Yes, we intercepted a problem that needed immediate attention, but we created more balance than we could have ever imagined. And that's something that we're very proud of. Lewis. This is my friend Lewis. His mother is a general dentist who referred to some orthodontists for over 20 years, and very happily so. Patients never complained. And when it came to her own children, she decided that after a while, maybe more could be done. Because after all, with all the sincerity that the orthodontist was trying to do, he was trying to put bumpers, he was trying to save Lewis some trouble. He had some sort of elastic running to the back. This orthodontist had some hooks. So this is a very conscientious orthodontist trying very hard to do something in mixed dentition, which is very difficult to do with conventional bracket and wire treatment. And after 2 years of this, Dr. Allen, Lewis's mom, realized, well, I don't see any progress. And she asked the orthodontist, can anything else be done? And the orthodontist said, no, this is all that can be done now. And she attended one of my lectures and she realized right away, as many doctors do, I usually will give my lecture and then afterwards I'll have a crowd of experienced doctors who care, usually doctors who care because their own children or grandchildren are in early treatment and they've given the matter some extra thought and they realized, well, something else can be done. So, literally 2 months after this valiant attempt to bring in laterals, to change vertical, to change some of the horizontal, none of this was really going anywhere. And that was really my personal experience with this kind of 2x4s or any kind of situation where you have a couple of brackets in the front with a wire and you have no leverage whatsoever. I realized after taking Nico and Maz's course, the Orthodontic Fellowship, that the physics of this aligner perhaps would allow for more control across the arch, across the plastic, with an aligner that does not discriminate between adult teeth, pediatric teeth, crowns, even edentulous areas. And all of a sudden, you're making room for the laterals. Within 2 months, his laterals were fully in. And you saw a total change in how these alveolar bones were fitting together. And this is a very, very dramatic effect that we see all the time. We just see a dramatic effect, what can and has been described as facial balance due to alveolar balance. And so the doctor saw it. She couldn't unsee it. She thought it might apply to her son. She brings her son in. She sees the effects right away. And now she's fully sold, right? Now, every patient that she sees at 7 or 8 years old, she sees differently. And I think that you'll find that you will see that in your own patients as well. And so when we see this patient, we see that the reality tends to be better than simulation. This is the outcome simulator. This is when the patient first arrived. She happened to have had a crossbite, so the parent came in. This is early mixed dentition, and this is what she would look like on the right, in this according to the simulator, with the dental effects and the dental correction. And usually when we show this to adults, oh, they love it. Wow, they cry tears of joy. But mom said, oh, is she going to have that gummy smile? And the reality is no. She's not going to have the gummy smile. She's not even going to have the constriction. There's so many things that we as orthodontists see here that can be corrected with Invisalign first, that we have to tell the parents, well, the reality is going to be better than the simulation. And indeed, after only 6 to 7 months of treatment, we'll call it, because we're seeing patients anywhere between 3 to 4 months, 2 visits worth of treatment. Look at all the detailing here. Look at how the midlines are now on. Look at how the subtle, right, arch development that we're seeing. Look at how incredible that arch development is over here in terms of how it will impact the eruption of the teeth. Not only is the crossbite fixed, but symmetry is being established. And look at how that looks when you look at her actual face, at her results. Again, this was in December of 23. So when you're looking at 2 visits worth, and she comes back later looking like a different person, we see this time and time and time again. And so it is no wonder why I've set on a mission, because once you've seen this change after 2 visits, time and time and time again, you cannot unsee it and you can't justify not doing it. And so we have patient after patient. This is from September of 23 to April of 24. 2 visits. People have pointed out to me, this child looks like a happier child. I don't want to get into psychology, but he's going from a child that was being made fun of for having Billy Bob teeth in school to a child who is truly smiling with his eyes, I've been told, right? And you can see it. This is the kind of impact you can have on the patients that you care about in just 2 visits. Once you see it, you cannot unsee it. This can only be described really as an orthopedic effect. Look at the vertical changes. Look at the transverse changes, how his dentition, albeit an early mixed dentition, is filling his buccal corridors, is filling his face. You can even see the symmetry with the midlines. This is happening time and time again. Is this even the same patient? I had to double check. You're looking at a patient that started in January and by June of the same year looked like a different human being. It looks like CGI, but it's not. These are the actual dates of treatment for this patient. Can you see this kind of change happening in early mixed dentition and justify not doing it? That's what I'd like to ask. Or how about this patient from February of 24 to September of 24? Okay, yes, I understand. There's been some other growth going on. It looks like a different human being, maybe even a different organism. But that's really what we see day after day. We've done 2,500 cases since June of 2020, did nothing before that. And this can be the transformation that happens in your office, where you have a deep bite and you have a narrow arch. And all of a sudden, those vertical and transverse, and then as we'll show you, the sagittal things are also being addressed. And then you have to ask yourself, well, what justification do I have for not doing this? What justification do I have for waiting for this bone to mature before I do something? You cannot justify that. Therefore, you must start. And so now let's get into start. Let's get into the acronym that I promised you I would show you. START stands for the following 5 things. The S in START is sequential staging. This is our dear friend Sadie. Her mom sent me this. Sadie's first day of second grade versus Sadie's first day of third grade. For us, this is all day, every day. Second and third grade is our wheelhouse. And these are the changes that we're looking for every single time. Mixed dentition with three-dimensional imbalance becoming early mixed dentition with beautiful three-dimensional balance. The sequential nature of aligners, which is undeniable, right? This is not a controversial take. The aligners are sequenced and they're staged. They are around the tooth and they're actually going one aligner after the other. And when the new teeth come in, once they've made room, we'll rescan and we'll bring them in stages. This is in stark contrast to one wire on brackets, where the tooth that's the most malaligned is going to get too much force, and the tooth that's in alignment is going to get force that you don't need. Marinating on one wire with like 1 or 2 points of contact, what are we talking about? When you have circumferential with attachments, even with John Morton in a room deciding exactly the optimal placement for attachments, and then you're doing it sequentially and staging, you are going to get such profound results that you have to actually ask yourself, am I ready for these results? After all, don't do this on an adult, right? Don't take the teeth out of the bone. But when you are doing this on a child, on an 8-year-old, you're simply moving the primary teeth. We're not really moving a lot on the molars. We're just using the incisors, keeping them in the same area. Look at the incisors that are toward the top of the screen. We've not pushed them out. We've not pushed them forward. All we've done is create an anterior arch form, and really an arch form all along the arch that accommodates the teeth. And then after a year, we have another few months, and beautifully, the adult teeth are coming into the new parameters that we have established. How exceptional is that? What this means is that you're establishing early alveolar balance by sequencing and allowing all of these teeth to come in stages where they're supposed to come. You're actually bringing beautiful, healthy bone around all of these teeth in ways that we weren't doing before. And that's a massive fundamental difference. Do you want to move teeth? Where would this premolar have erupted if we hadn't moved these teeth at 7 or 8 years old? Do you want to start moving them? How do you justify starting to move them when they're 9, 10, 12 years old? You can't justify it. And so start now is because of the sequential and staging that we could do now. Thickness is the T of start. The thickness of the aligner is a blessing. You could use it to resolve crossbites, as we've done over here. This is one of the early cases where I had no clue what I was doing. It never occurred to me to disclude them in any other way other than to have the aligners differentially, one on the top, one on the bottom, and boom, they are treated separately. I don't know what the clinical plan would be for an orthodontist who's trying to do this in conventional brackets and wires. Where are you putting the brackets? Where are you putting the wires? And yet we were able to do this easily while the patient was at home. You're taking the force of occlusion when it comes to the thickness of the aligner, and you're redistributing that force, which some orthodontists complain about. They say, oh, why am I treating my adults and getting posterior open bites? Well, the force of occlusion in the posterior is much stronger. And so here, if you design your case properly and you redistribute that force to the anterior, you can have the kind of effect on gummy smiles that you cannot have in adults non-surgically. And so that is a blessing. So another blessing of the thickness of a liner. Here's another case. Well, I don't like seeing the premolars because I feel like that's already a little bit later than I'd like to. And here mom comes in, she complains. My boy is not wearing his aligners. Look at the front. It looks exactly the same. Nothing has happened. I take a scan. I look up on the Align Oral Health Suite on my iTero. I select the time lapse, and the time lapse is about 1.5 visits. And I look and I see, look at the molar. Full class 2 has now become a class 1. And daylight between the primary molar and the permanent molar. In that daylight, I know, has wedged in the thickness of a liner. Look how that thickness of a liner has actually created a beautiful class 1 correction in a way that is very difficult to do in any other ways. This is the right approach as far as the vector. Now he has no traction. This is what I call the wedge effect. It's a double entendre because it is a golf club as well. But had he been coming in from the side, he'd have no leverage at all. Here he doesn't have leverage because he simply has no friction. But this is certainly where the aligner can come in. When it wedges in, it creates a tremendous, a welcome force. Look at the difference over here. This is not an extraction site, doctors. This is a a liner wedging in between the central incisor and the primary canine and creating a force already on the left side. The lateral is in. This is the same patient, of course, on the lower. You still see some of the ravages of the space maintainers that had dug into the gums. So these effects didn't take very long at all. It was in the very next visit when the patient comes in, and instead of this crowding, he has alignment. Instead of this space loss, he has space gaining on the lower. And on the upper, instead of having no lateral, the lateral is already in. I see that all day, every day. And on the opposite side, lateral not in yet, but where heretofore the two teeth were almost juxtaposed and touching, now there is room for the lateral. Incredible power we don't really have. I mean, you could put a finger spring in here, or an open coil NiTi, I suppose. But why would you do that along primary teeth? That's a very difficult thing to do, and it's coming along on the buccal surface. Whereas here you have the wedging effect of the thickness of a liner really doing the work for you. And so you have sequential aligners, thickness of aligner, anterior arch development is a very, very important feature. And I must highlight how a patient like this needs anterior arch development more than anything else, more than an RPE. I don't know exactly what treatment modality you'd be planning to do this without anterior arch development. Now, doctors, when they see this and they see how we've developed the arch in only 7 months, they say, well, doc, you took the teeth out of the bone. Not so. We have all the ability. We have tooth movement tables. We can see exactly where we took the teeth to 0.1 millimeter of accuracy. But even if you just eyeball it and you can orient it, because the line does orient it exactly how it was sitting before, you could see that the incisors haven't moved anteriorly at all. Yes, the laterals certainly have. Yes, there is room now for the canines, but we haven't taken any teeth out of bone. In fact, we've taken the laterals and put them nicely into an arch form within bone, all in 7 months, all in a treatment modality that couldn't have really done it any other way. That applies to the lower as well. Look at this anterior arch development. Are you going to be extracting primary canines? I hope not, because you really don't have to. You'll ask me, well, what about anterior incisor angle? Well, look at your anterior incisor angle. You could look at that. It's all on your tooth movement tables, and you could do this just from anterior arch development without affecting that adversely. So I encourage you to do that. I liken it to taking the narrow arches of Santorini and converting them in the anterior to the wide arches of the superdome. It is a very, very profound and important movement of a pediatric aligner. It makes room for laterals, it makes room for canines, and it simply is one of the most profound things that we can do for our pediatric patients. We have this beautiful case from my dear friend, Dr. Manali Ibrahim, and she was onto this very early. She wanted to make room for laterals in this case. She noticed on her radiographs that the laterals were in risk of resorption, and so she wanted to get on that very quickly. She considered treatment options and she realized, well, if she's extracting teeth, she's only going to make less room. If she does nothing, she's only going to allow the bone to mature. An expander would only address the posterior braces. You're not going to put braces on just two teeth in the front. And so this is basically us running through her case. And of course, we're used to these results. The midlines are going to align, the vertical rabbit teeth are going to intrude, the sagittal will actually be much better. And so we're seeing that the results are predictable because the patient is, in fact, so flexible, and they are profound. And so this is just a great example of how 10 months, 2 or 3 visits is how long it takes. Now, this is the initial and the final. You'll notice in the final that the canines also need a little bit more room. Will they get enough room? Yes, they will. Here's the thesis, doctors. When you have developing aligners, okay, when you have developing dentition, this is what's happening at every age. Here are the pediatric teeth at 5 years old. At 6 years old, the teeth are starting to come in the posterior. 7 years old and 8 years old. This is our wheelhouse. Whoa, stop right there. What do we have here? Laterals looking to come in between age 8 and 9. Primary teeth, molars and canines with still some root left that they can be moved. It is at this stage where we are going to be setting the perimeter for the future alveolar bone. If we were to wait till age 11, it is already too late. We already have the permanent premolars, I should say, bringing in with them that denser bone. And at this point, any movement you do can either tip the teeth out of bone, or it won't move, or it will move the teeth through bone. You don't want to do any of those things. You want to get before this age. You want to start now. And so when Manal, Dr. Ibrahim from Illinois, was able to actually make room for those laterals, she was still an early mixed dentition, and she has, through anterior development, the ability to also make room for the canines as well, which is very important. That's what her patients look like. This is a little bit more typical of what my patients look like. And so clearly, when you see a lateral like this, you know that the canine can't be far behind. And certainly the radiograph bears that out. Dad says, well, the orthodontist says, wait. Everybody loves hearing that. And so he waited. It got worse over the course of the year. We were fortunate through anterior development to bring the canine in. Now, of course, I'm telling you this anecdotally. In fact, I'd go so far as to say in 2,500 cases, after doing approximately, let's see, from 2003 when I graduated in NYU until 2019 when I got to Maryland, I would do approximately 40 to 50 canine exposures a year, even though I was the RPE whisperer. I was giving RPE to so many patients. Since June of 2020, we have not had to do a single canine exposure. That is compelling anecdotal evidence. And so this patient was no different, and I attributed it to giving the space where the space belongs. Now, of course, once CBCT is going to be offered in Invisalign first, if it is, once the proper data and metrics are applied, there will be no question as to why there's room for the canines, and all of our early treatment claims will be seen with metrics, and then the burden of proof will be on everyone else to explain why they're not doing that, because it really is so profound. And so we have sequential, thickness, anterior arch. The R of START is refinement. Some people consider refinement to be a dirty word. Why would you want to see the patient and scan them more often? And I ask you, why not? Here's Anwar. This is 2 visits in, and I'll show you what those 2 visits looked like. Why were we able to resolve his crowding, overbite, and overjet? Well, because we have refinement, or right, what we call staging. So staging and refinement are the same thing. It means that when the patient comes in between visit 1 and visit 2, 3-4 months in, already the laterals are in. We see that every single time. Once the laterals are in, you're going to rescan. Of course you will. And then you'll put them into proper position. And now watch as the vertical corrects, as the sagittal corrects, as the anterior arch development is correcting. We're looking also to 0.1 millimeter of accuracy with the occlusion. I ask you, doctors, when you are treating mixed dentition or any dentition with orthodontic treatment, are you mounting your cases on articulators? Are you looking at the occlusion with 0.1 millimeter of accuracy? And if you are you repositioning the brackets 0.1 millimeters? Well, we do all of those things. So even though we're seeing the patients less frequently, the mindfulness of course correction, or staging, better said, of that refinement brings is one of the hallmarks of orthodontic treatment. It enables us to get these beautiful results, balanced results, in just 2 visits or 3 visits as we stage it. And then, mind you, 2 years later, we barely have done anything. So this is very typical of our timetable. We have 8 to 10 months initially, followed by not much, sometimes not even any retention at all. And then we just follow the teeth as they come into beautiful alignment. We have a lot of questions about retention. There's not a lot of retention that goes on in between because it is so retentive because it was done so early. Here, I'll get out of the way so I could show you. This is what drives me a little bit bananas. The notion that in the past, I used to wait for this patient. I used to send him home and wait for him to be this age before starting treatment. That is truly sad, because once he gets to this age, it is indeed too late. All the vertical, sagittal, and transverse things that we accomplished early now have to be done in denser bone, and that's much harder to do. And so you want to avoid that. You want to start now. And so timely orthodontics doctors do not miss the opportunity to establish stable alveolar balance. And so start sequencing thickness of aligner, anterior arch, refinement, and 3-dimensional right correction. And so you can't, when you look at this beautiful patient, you can't unsee the value of an early aligner appliance, because after the scan, I noticed what this patient was headed for had she not been seeing me for a second opinion, because she heard of what we do. Yes, she would have been headed most likely for an expander, I suppose, and a headgear, maybe a high pull headgear with a utility arch, First, in terms of sequencing, she would have to somehow address this anterior crossbite. So she has the anterior crossbite. She has vertical issues, obviously, with the great gummy smile. She has transverse issues because no room for the laterals. And she has sagittal issues, again, with the anterior crossbite and some other sagittal issues. What kind of sequencing would you need when you're using these two-dimensional limited interceptive appliances? I suppose you would need to use nearly all of them. I guess the high pill headgear, the expander, the Holly. How are you sequencing it? How long would it take? What would the patient be experiencing? How predictable would the results be? As opposed to with an aligner appliance, literally, let's see the timeline. Okay, 2 visits. Okay, 6 months. You're getting the gummy smile is gone because you've used the vertical. The laterals are in because you've addressed the transverse. Of course, the crossbite is corrected. That's so easy with the thickness of the aligner. And of course, the punchline of the joke, you have your perfect midlines because you can, because you've established beautiful symmetry in this patient. And it was easy for the patient, easy for the doctor. And so we see over here, over time, how this has developed. The lower incisor, which is not addressed in any of the other treatment modalities, is now further in bone. There's room for all the other teeth. Obviously, the anterior arch is beautifully developed, and we have room for the laterals. The lower arch, again, is addressed. The beautiful alignment, the beautiful coordination between the upper and lower arches. All of this is what we call dentoalveolar osteoshaping. That's one way of putting it. We are not really addressing the occiput, maybe not even the mandible, but certainly this E, the dental arches. The osteoshaping of the dental arches is so profound. And so it doesn't have to be in like super complicated cases. Even a patient like this, normally you would send this patient home. But why would you send him home where in 6 months you can get, let's look under the hood, these kind of profound changes, right? Where you're getting subtle arch development. I would not call this skeletal really, but it's dental alveolar arch development that's going to allow teeth to erupt. Obviously, the lower crowding you're resolving. The notion of taking out primary canines seems ridiculous when you can do it this way without overextending the teeth, just with alveolar shaping. And of course, you're getting some sagittal. And of course, the punchline here is the midlines are aligned as well. So, how could you justify not doing this in soft bone when you actually can do it? That's really the question that we're trying to address. And so there is Sadie. I don't want to be on her face, but sequential. Start. Thickness, anterior arch, refinement, 3-dimensional. This is all day, every day. And so we no longer view phase one as early. We view it as timely. We don't even call it phase one. It's timely, comprehensive treatment. Everything else is hopefully not too late treatment. I hope that that is clear to you, doctors. And what it says under my face here is that the earlier the start, the better the results. I mean, this looks like CGI or 5 years of treatment. It is not. He's still in early mixed dentition. He simply looks so much better because he got the benefit of treatment when it was most appropriate for him in the early mixed dentition, when we can be most effective and have the most profound impact. And so, as a line speaker, I'm always asked to say the speaker's disclaimer that this is my opinion, but my disclaimer to disclaimer is definitely don't hold this back. Share this. We are a part of a community, and I believe everybody should be doing this. And I'll end with a rant. Okay, Align asked me to make this disclaimer also. This is not an Align appliance or claims. This is laughable, right? We know that this is not an Align appliance. What is this appliance, anyways? You'd be surprised. It is a well-known appliance that makes these claims. These are not Align's claims. This is the makers of this appliance claim that it's much less painful than braces. Now, as you look at these claims, you'll notice clearly that these claims are applicable more so to Invisalign First, much more so. And yet, this is an appliance that's very popular. You can go, there are centers all over the world where you can learn how to use it. It's an appliance that has all the right objectives. So I'm not here to be negative about it. These are really noble objectives. Less painful than braces, yes. Removable when necessary, yes. Invisalign First, barely visible, which makes it cosmetically pleasing, yes. Focused on facial development and airway health. Well, we are. The direct causation needs to be discussed and studied. Empowering the patient, I have found that, yes, thousands of times I have seen that. And so it certainly is empowering to the patient. Invisalign First. Well-developed faces, minimizing risk for TMJ problems. Okay, I've not tracked that in a metrics way, but certainly I could see that all of these objectives are noble objectives, and yet what are we talking about? Is that what this appliance is doing? So, as fate would have it, this appliance, which is, like I said, a popular appliance, walked into my office. You probably won't see this anywhere else. This is our Lumina scanner, or my son, God bless him, is my assistant. And so he was scanning, and he didn't realize, because he saw bands, he didn't realize it was a removable appliance. So he scanned with this appliance in place, and we see a telescopic crossbite. The mom was lecturing me, and she was saying how maybe I should give this to her son. And after all, with this, I said, well, what about the telescopic crossbite? And she said, well, the doctor said he's going to do that later. I said, okay. But you could see none of the start, right? There's no sequencing here. There's no staging. There's no anterior development. There is no occlusal force. There is no any of the things that we actually see as the details, the important physical advantages of the pediatric aligner. And yet this appliance has tremendous traction in the orthodontic world. It has fans, and it should, because the objectives are really, really important. But the fact that those objectives and more with our aligners is something that should cause us, inspire us to be more proactive and to not miss the opportunity to establish stable alveolar balance. We want to offer timely orthodontics. And so I finished with Anwar here because he came in recently. So this is now 4.5 years after treatment. It's been a very busy 4.5 years. We went from never using any Align for any reason to now 2,500 patients later and Blue Diamond, whatever. That's not the point, right? The point is that we are providing incredible, stable treatment for our patients. I will tell you this, and I probably shouldn't tell you this, but Anwar doesn't wear retainers. Anwar doesn't really know that retention is an issue. He came in between the treatment that he had in the initial phase 5 years ago. To think that he was 8 then and he's 13 now, to think that in so many orthodontic offices he'd be starting now with his bone the way it was 5 years ago is absolutely unconscionable. Okay, it's something that we can no longer do, and so we have to spread the word. That is our mission, to start now and to establish timely orthodontics. Now, Anwar, as I said, once he had that established alveolar balance, he had teeth erupting into the right place. He never needed retention again. Do we give him a Vivera retainer at the end of treatment? Yes, we do. But as we watch his teeth fall right into place, it wasn't an issue of retention, because retention is simply for those who start at 12 and 13 when the bone is already too dense and it's already has been established in its unbalanced proportions. And so when that happens, of course, there is a great tendency for relapse. But the way he is now, there is no relapse on the horizon because his teeth were guided into place beautifully. So I hope that that inspires you to at least look into starting now. All of our modules are designed to teach you how to do it, and our community is designed for us to discuss what are some of our successes, what are some of our failures, how we could do this better and better, making the world a better place, one young smile at a time. And I thank you, doctors, for your attention, and I can't wait to go on this journey with you as we usher in the new orthodontics, where the promised land is the 8-year-olds and their timely treatment.